Thank you for an exciting case this morning. We're really excited to be back with you for the second one. Let me introduce who's up here on the panel with us. My name is Daniel Han from Sinai. We have a wonderful panel group of Dr. Ajit Rao, Dr. Darren Schneider, Dr. Sahil Parikh, Dr. Kumar Madasari, Dr. Liz Genevieve, and calling Dr. Rami Tadros, who will also be joining us soon. And then let me pass it over to you if you want to. I think you were going to share with us the end of the last case and then share with us what you're going to do here.
Absolutely. So again, pleasure being back with y'all again. PK, thanks for inviting me to your meeting. We're in Raleigh, North Carolina, have a great team here. Tina, Alexis, Justin, several reps. Okay, well listen, this gentleman actually visited me. Let's just see, today is Friday. He visited me Wednesday, and I spent an hour on the insurance company, with the insurance company yesterday, having him, so we could have him as a live case. But he drove 5 hours. He was seen by 2 surgeons who said he needed bypass. And his history is that he's 67, typical comorbidities, diabetes, high cholesterol, hypertension, heart disease, heart failure, and has had a stent placed to his common iliac artery 12 years ago. And so he comes to me with an ultrasound showing me that his common iliac stent on the left side is occluded. So that's all I know. And then let me show you the angiogram. So this is the angiogram that we're going to start with. I just took it about 20 minutes ago. I went through a radial approach. Okay. And let me also state that this gentleman is 6'5". Okay. So he's rather tall, but I used a 135 centimeter 6 French radiance sheath from the radial. It's a very nice thin-walled sheath, this hydrophilic that really traverses down there. And then let me show you the runoff real quick. I placed a pigtail down the distal. You see these large lumbars coming off. And then you see the common femoral come back, and you see a piece of the external iliac, and that's where it's occluded. And then I think you can appreciate as profundas and SFAs, popliteals are widely patent. And to be honest with you, he's a rather large man. We can tell he's got tibials, and he looks to at least have 2 vessel runoff below the knee bilaterally. I wouldn't be surprised if it's not 3 vessel runoff. But regardless, that's about what we got. So this is a shot just without subtraction. You can appreciate that stent in the left common iliac. So what we did is we were able to extend a 135 centimeter 6 French sheath from the radial to the distal aorta, just to give us as much push as we could if we needed it, but also to give us visualization from above. I then took a short 7 French sheath and placed it in the common femoral. To be honest with you, the pulse wasn't that good, so I looked at it angiographically and stuck it angiographically since I had visualization from above. We then took a 0.18-inch V18 from below. Let me see if I can show you this real quick. All right.
Can I ask a question while you're pulling that image up? There's a bunch of surgical clips in that groin. Does he have a surgical incision there? Do you have some sort of procedure there previously?
That's a great question. So he's got some scar tissue down here. Supposedly he had an aneurysm repair. To the best of his recollection, it was in the aorta somewhere. So I don't know if he had someone come through this before and they had to surgically, fix it. I'm not sure from the access. To be honest with you, I don't have those records, so I can't tell you. But he does have some scar tissue down here, and it's not on the other side. So I don't know exactly what the surgical intervention was.
Got it. And maybe I can just pause for a second and open up to the panel. Any thoughts about access in this case? We have a good diagnostic from above. How are we tackling this?
Yeah, I did this case last week. It was the same sort of a situation. I think that the challenge is always whether or not you have enough pushability in an antegrade fashion. I think there is a desire to try to get into that nub from above. But here, George showed elegantly, probably just with his access wire, he crossed this occlusion and stayed true lumen all the way up into the aorta. But I think that dual access is probably your way to go. And it's not uncommon that you'd have to do some sort of rendezvous somewhere within the iliac, which is always a little bit hazardous if you're not careful.
Can they ring down?
I think that that angiogram initially was very telling because that the reconstituted external iliac had a nipple. So you know fairly well that your initial wire, like you said, the 018, is probably going to traverse through that, and the common iliac had a stump. So you have two things on the angio to tell you that this is going to go probably well from both sides, but I like the idea of going from the common femoral side on the left and just having that radial axis. That's good to have that as to map it.
Darren?
First of all,
Yeah, so you're absolutely right. So what we did is at V18, we were able to make a tight J, and it got into the stent cage, and then we used a straight navicross, short, 90 centimeters, and was able to follow it, and given it the support, it popped right through into the aorta. What we did is we took, and I think you can appreciate this. This is the exactly what I was telling you. This is the navicross going over the V18. And then just to make sure that I knew where I was, I injected through it, because there's been many a times, and I think y'all can attest to it, that you think you know where you are, but you may not be where you think you are. So I just confirmed that I am in the aorta and I'm not in the wall of the aorta. Then I took an 0.14-inch Mongo wire, put it out, and now what I've got is an IVUS. This is an 0.18-inch IVUS. And then what I'm going to do is I'm going to go ahead and just pull it back and show you exactly what we're dealing with here. Can you record for me?
You know, I was wondering, does anybody else, it looked like almost there's the calcification on the iliac. It looks like it was, maybe that's where the aneurysm was. And the stent, I mean, I didn't see the internal coming back.
I mean, I don't see an aneurysm repair here. I mean,
No, I know the stent I think was used to fix.
Got it.
Because if you look at the calcium around the stent, it almost looked like it was much wider than the stent.
Darren, you were going to say something.
yeah, I mean, first of all, as a surgeon, I still think that this is a totally endo-first case. And I think the things that really lend itself to an endovascular approach are the fact that you do have a stump of the common iliac that's open, and most importantly, the common femoral is open as well. So you can cross this and treat this with an endovascular approach, especially in a 6.5 foot tall individual. I probably would not have come with a radial approach initially because you're limited in what you can do from that. Typically, I would have started with a contralateral femoral approach and shot my diagnostics. And even with this case, you can come up and over from a femoral approach using a steerable sheath if you needed to, and not necessarily have to come from above. But there's certainly more than one way to tackle this case.
All right, we're seeing some IVUS images come across our screen. George?
Yep. Seth, could you back those up for us so they can see them? Yep, just show them the stenosis. Yep, keep coming on through. So I think everybody can appreciate this is pretty homogeneous. There's the stent struts. You see all that shear. What I think is very interesting is whoever placed this stent, I think they're undersized. Yeah. Look at the vessel lumen around that stent. So keep going on down. Seth?
It's a 5.
Yeah.
What is the size of that stent, Seth? 1, 2, 3.
4 or 5. It's 5.
Is it 5?
Yeah, it looks like a 5.
It's like a 5.
The vessel's at least 9.
Yeah, at least. And so I bet you they undersized it, and that's one of the things that led to the occlusion. Actually, it's a 6.5, 6.7, maybe. They took a 6.0 stent in there, maybe a 7.0. Okay, perfect. All right, so Seth, keep coming on down and then just show us the distal piece of this. You see how it's almost like the stent's not opposed to the wall. See how big that vessel is? Yeah, right there, Seth. Give me a measurement just across there.
I think,
all right.
Is this what you were
He's
referring to,
doing
Kumar?
that.
You were thinking that the
Strategies, y'all. What do you
stent was
think?
put in for an aneurysm in that
I
area.
think so. I think that's
Yeah,
what it looked like on the subtracted there. You could see the calcium way too outside the stent.
Yeah,
The internal's gone
yeah.
too, so something may have happened.
Doesn't look quite like an aneurysm, but I could, it's a bigger vessel there than
I mean, it's definitely undersized. I don't think it was a covered stent. So
It doesn't
it'd be
look like a
strange
covered
to
stent.
treat an aneurysm with an undersized bare metal stent.
Okay, so what are you thinking?
So So I'm thinking that number one is looking at the characteristic of the plaque and the size of the vessel, and you've got an undersized stent. I think there's only one way to treat this, and that's with a covered stent, and that's with a VBX. So then you can cover the whole area, and it'll seal whatever your previous lesion was. So that's what I'm thinking.
All right, let's open it.
What are y'all thinking?
Would you do anything to prep that with either atherectomy or?
I'm taking a 5. I'm gonna take a 5.0 balloon, and just to get some flow so we can get a better look at it.
I was thinking, I've done a couple of these cases now where we use the Rotarex to try to, debulk the inside of that stent and try to get better expansion.
PK.
Yeah, I'm just curious about, is there anybody concerned about toothpasting? If it's thrombosed and you balloon it, do you worry about embolizing it distal or even maybe putting it over into the other contralateral common?
Yeah, I guess, George, similar, the panel is having discussions about, we're talking about vessel prepping, we're talking about toothpasting. I guess there's some concern that there might be some thrombus, that as you're ballooning this, you might be moving that thrombus into collaterals or places that you don't really want. I don't know, would there any other adjunctive devices that you guys would use before a covered stent for the panel? Liz?
I mean, I think it looks pretty homogeneous on the IVUS, and I don't know the chronicity of his symptoms. I'm assuming that this is not something that acutely happened in the last few weeks, but George, you'd know better than me, but I think that, one of the things that I worry about is also protecting the contralateral side with regards to, I think you're going to be able to probably seal that, but I think your covered stent's going to be the best way to do it, get a flow lumen, be able to see what you need to treat.
And I guess this is going to be the question. We have a perfect angio that's up here now. So I guess when we're taking this lesion looks like it's pretty much up to the bifurcation. Looks pretty close. I mean, are you guys worried about toothpasting to the other side? Who would extend this up with a, kissing stents or something like this?
I would definitely protect the other side because I do think that that's a real risk, and I wouldn't hesitate to use kissing stents if I thought I needed to.
George, the other thing is that the right side looks small, which is probably why they undersized the stent in the first place. So I wonder if when you IVUS the right side, it's also a lot larger than it actually seems. And there's a laminated thrombus making the lumen look much smaller than the actual vessel.
Would anyone on the panel try to land a unilateral stent rather than do a kissing stent?
I definitely would have right-sided access and a wire up, at least to protect that side. There is a small nub of that left common iliac that you can see on the angiogram. I do agree that having double access in this kind of case is going to be really important. You could have a wire from the transradial access, and you could use something like a Medtronic stent with an entrust system that's 150 length to get down there, and they make that in an 8 millimeter. So if you needed to do it transradial, you could, and not access the right femoral. But I agree with everyone else's kind of sentiment. I'd be worried about possibly toothpasting here. I'd want to debulk the inside of that stent, either Rotarex or Jetstream or something to potentially clear the inside of that stent the best I could.
I mean, there's some gigantic collaterals there right at that bifurcation. Would anyone consider a bare metal stent and not a covered stent, or was everyone going covered stent?
Definitely covered stent.
Man, those are the most vigorous head shakes I've seen. So I think everyone's agreeing with a covered stent here. So George, are you thinking about treating unilaterally or bilaterally here?
I'm going to treat unilaterally. I'll protect my right side from above. So that's a good idea. So we're good from that standpoint. That's a nice thing about having a radial or a sheath that comes from above, whether it be from radial or brachial. So that's nice. And then the other thing, I was put up this bifurcation. This is a very nice bifurcation. It's not steep. So I think, and it's got a small nub. So I think I'm hoping we'll be able to land a VBX right there at the nub. What I would do, again, if there's anything that I would debulk with, it would be a laser. I would not use a the rotational with the thrombectomy, you throw more downstream than you do pull out of it. So I can't protect myself downstream. So what I would prefer to do is probably undersize the balloon, see what it looks like, and then go, if I can sneak a covered stent in there, trap all of it if I can. And my hope is I won't toothpaste it out like y'all are saying.
Can we see where the common femoral comes back? It's pretty close to that inguinal ligament, pretty far down, right, where it comes back?
Yeah.
It is.
Just at the top of the femoral head.
So I guess the question is, like, how far would you be taking this Viabon down into that common femoral artery distally?
So that's a great question. So, you've got to, so what I've got is a 7079 that you can take to 11 millimeters. So what I was hoping to do is take 279s, lay short, and then just post it bigger proximally and taper it down, was what I was thinking about.
George, one thing that I've had experience with is, I don't like using VBX in the external iliac, especially in the distal portion of the external iliac. So if you consider doing, in the future, if this patient needs any surgical procedures, if you put a standard Viabon, you can clamp that easily with a Fogarty hydrogrip clamp. And then you can clamp that, get control of that vessel. A VBX cannot be clamped. And for that reason, I don't like to use a VBX in that distal portion of the external. So in the future, if this patient needs a bypass, needs even an aortofemoral bypass, anything you need to do, if you need to get control in that area, you cannot clamp a VBX.
Aaron.
Okay, so that's great. That's great advice. So what we could do proximally is use a VBX and then use a Viabon distally.
That's what I do.
Just depending on the length. The nice thing I like about the Viabon is that it's accuracy. So that's the one thing we have to be conscientious of, because like you said, my access site to where we're extending to is very close.
That's exactly what I would do. I'd VBX proximal and extend with a standard Viabon.
Darren.
Yeah, so I like that idea, but I'd use a self-expanding Viabon first. It's going to be smaller, and I'd put that in first, lining up to that stent, and then I'd use the balloon expandable VBX to extend proximal up to the bifurcation. With the balloon expandable, you have that radial force that you need and the precision of the deployment. So I would do it that way. I agree with Rami on the liking the self-expanding Viabon in the distal external iliac. I think that's nice.
Sahil?
I guess the question is which size, because your access is going to limit what size you can put in. Self-expanding Viabon 7 goes through 7. Bigger than that, you're going to need a bigger access, right?
Low profile 8, I think, right?
Yeah, you can.
You can
go an 8. You'll get an 8, but do you need bigger than 8?
I think for
The idea of using VBX is you can tailor the size.
Yeah, I mean, the existing stent there is 7 millimeters. So if you use a 8 millimeter low profile Viabon in the external as your first stent, as Darren mentioned, and then extend with a either probably a 10-0 VBX.
Well, we do have 4 surgeons on the panel, and we've talked a lot about hybrid procedures in these kind of cases, and we're talking about taking this distal Viabon fairly close to the femoral head. Would anyone consider a common femoral, cut down and also be able to kind of fix that proximal portion open? I don't know.
You got to be careful with your femoral access that you're distal enough on the common femoral that you have room to basically deploy that safely.
Dr. Rao?
I was going to say, I think the other important part is the history. It looks like this patient's had surgery on the left side, so knowing exactly what was done and what you're going into would be important to know. Get those records first.
We had an aneurysm repair of some sort, so. All right, so it looks like we're doing pre-ballooning of this lesion, so we can send our Viabons. What size are you using, George?
So I undersized it. I used a 5.0 just because, again, I don't want to push anything into the other contralateral iliac. The other thing I'm just going to tell you, I've got in my ear telling me I've got 10 minutes left, so I'm going to try to work as we talk, not to be disrespectful. So
how about,
great.
If we're going to do that,
let's see what we've got now.
Okay, we'll take a look at this run. Okay.
So we definitely got flow.
So George, if it's okay, then we'll leave you to it. We'll go to a talk. We'll come back to you to kind of look at kind of what the results are.
That sounds great. Thank you all very much for your advice. All right, guys. So really great results so far. So what we did We took a 7079 VBX. And again, this aortic bifurcation, you couldn't ask for a better aortic bifurcation. It's not steep, it's away from each other. And we were able to lay that VBX right, actually, let me see here. Here we go. Here's your VBX, look at that. Beautiful. Okay, then what we did, and I greatly appreciate all the comments and advice regarding the Vibond. We laid a 100 millimeter 8.0 Vibond distally. And then what I did was I placed it by injecting through the femoral sheath. And so this is the placement. This was the result. And then what we did is we went in there with an 8.0 balloon, and I posted the proximal segment to about 8.6 millimeters and the distal segment to about 8 millimeters. And this is what we got.
I think that looks
What you
great.
think?
You know, I think a lot of us ended
Looks
up
pretty
seeing-
good.
I think a lot of us were looking at kind of what you were doing during some of the presentations. I think we saw you take a lot of shots of that aortic bifurcation. You had to stick that landing, and I think you definitely stuck it. It's a very short area with very little margin for error. We were talking about toothpasting stuff out of that common iliac to the other side. Did you do anything more than just leave a wire? Did you think about putting a balloon up on the other side?
With this iliac bifurcation, I think you can appreciate, I mean, you've got a rather large landing zone and it's far apart from each other. So I didn't. So we could have, and the thing is, we could have come from the radial approach. We had these, currently we had the radial balloons, the sabers that we could have gone down. They have a 190 centimeter shaft, long rapid exchange that we could have blown up and protected it. But I think we did pretty well. I'm just looking, was that stenosis there before?
Are you looking at the distal? On the right side,
no, at
proximal.
the right. Yeah, hold on, let me see here. So, interesting. So maybe we did get some toothpasting there. I don't know. You see that? See what I'm saying?
Yeah.
This is what we started with. You see it right there at the proximal region?
Yeah. I was going to suggest IVUSing that proximal stent to see whether there's any issue there right at the stent edge as it's just entering the aorta there.
Oh, yeah, we can do that. Let's use the IVUS and we'll go in and look at it. We can do that right now. We got the IVUS on the table. So we'll IVUS the whole stent that we just placed.
You can IVUS from
and
the
then
wrist,
what we're
too.
going to do is I may go in there and balloon the right common iliac.
Got it. It's also kind of hard. There's a lot of bowel gas right over that area, so it could be a little difficult. Panelists, any comments?
I would consider, if you have it, a 6 French 8 millimeter self-expanding stent in that right common, and potentially either kissing balloon once the stent is in position, or kissing stent and raise that slightly.
Darren.
Yeah, I think that the IVUS suggestion is a good suggestion. We saw in the initial IVUS that stent was undersized. The vessels were actually a lot larger than you thought. And so my concern is that it looks like you stuck the landing nicely, but is that edge still in some thrombus proximally? And that would be a reason to use, kissing stents and raise them up a little bit so that this doesn't fail for that reason.
Yeah.
Looks pretty good. Okay. Go ahead and record for me.
Right there. Right there.
Yeah, and the other issue with the covered stent sometimes is it's hard acutely to IVUS through them sometimes because they have air in the PTFE, and so you don't penetrate. So you can see outside the covered stents, but at the edges, but not where you've covered usually.
Yeah, you can see a little something right there.
It's really hard to tell. Yeah, what I'm going to do is, let me pull it back and see. I'll take a catheter in there and shoot it directly and just make sure there's not something at that stent edge.
Definitely.
It seemed like there was.
Yeah.
Yeah, there definitely seems at the proximal edge.
Okay.
And I think this is why we left that safety wire on the other side. We were talking a lot about homogeneous kind of thrombus throughout the entire segment. I think we're seeing, even though we stuck the landing, this is sometimes the fear. You're inflating a balloon in a fixed space. So that thrombus needs to go somewhere. So sometimes it can go into other side. But I think this angiogram will also show us a little bit a better picture.
Boston catheter real quick.
One of the other considerations with the VBX is that it will shorten. So you use a 7 millimeter
just gonna take a
VBX,
little picture.
posted it to 8.6, that's going to shorten a few millimeters on either end. And so if it was perfect initially, it may have regressed.
Yeah, great comment. So that's the reason when you place your VBX, you go in a couple millimeters like we did, because it's going to foreshorten.
Yeah.
So absolutely, I agree with you. But we should have hit it by doing that. I think this may be stuff that was pushed up, if anything.
Yeah, you're probably right.
So George, if it's okay with you, we have one more talk to do. I'll let you investigate that. We'll come back to you. Is that okay? I think everyone's holding their breath, trying to see what Dr. Adams and his team
We
are
got to
doing.
raise it just a little bit and then flare it. And I think, you see, right at the top of that stent.
George, can you hear us? We're back to you.
Yeah, how's it coming? So, all right, I've done just about every maneuver possible. There's no gradient. However, there is something right there at the top of that stent. I'm not a big fan of, unless I've got to, putting in, raising the corona of it. I don't think that's reasonable. What I would do is I'd extend, I've got a 7.0, I think it's a 29, is that correct? 19 VBX, I'll raise it up another 2 millimeters or so. The question is, do I just protect it with a balloon from above after I get it in place? That's what I would prefer to do rather than having 2 stents in both sides and raising the corona, because I'm going to lose those large lumbars.
Panel.
You could extend it proximately on the right side with a bare metal. I mean, it's a really wide aortic bifurcation there. I think that you don't necessarily have to place covered stents on both sides.
So you're thinking of a balloon expandable bare metal stent.
Potentially. I mean, right now it doesn't look like it needs it. I think that left VBX needs to be extended a few millimeters. I agree. Yeah, it's maybe protect it with a balloon, as you suggested. I don't know.
Darren?
I have kind of the opposite approach. I don't have a problem placing stents and raising the bifurcation a little. I don't like the stents to cross, but I think it's fine to go, 5-6 millimeters into the aorta. It's a large aorta. The likelihood that you're going to occlude all those lumbars is low. I also don't work that hard to save those lumbars. They're there because the iliac was occluded, which if you do a good job fixing it, you don't need those lumbars necessarily.
Don't prep it.
And at least
get it in
personally, I can't remember a case in my career that came back with a real bad problem because I occluded a lumbar at the aortic
subtraction.
bifurcation.
Take off subtraction.
I wonder if anybody else
Just
has.
do a single shot real quick.
So I think it's the same. I think when we hear about any vascular bed, if you see large collaterals, it's there because there's a significant kind of lesion that's preventing blood flow there. So if you do fix some of that, perhaps they're not going to be as important as they were before. This is still, we have a very long covered stent through the common iliac and the external iliac going almost down to the groin. So while we do say aortoiliac kind of patency is great, this one might be a little bit challenging. This is a failed prior endo procedure with the stent that's already in there. So, maybe the collaterals are truly important so that if it does go down, it can salvage this patient's leg. In this scenario, if we're thinking about extending the VBX proximally, would someone do a kissing balloon or even if it's...
I'm looking at it. I'm sorry. Go ahead.
I would. Your point is, I think you're going to say the same thing. Is that having a raised
Give me a
neocarina might be better
70-40.
than a blocking balloon from the contralateral, which you can bring up down from the radial, would be just fine.
Hold on.
Yeah, I think I would
Let me
probably
check the
raise
for a
that
second.
and do kissing stents, and I would probably just use the radial access and.
Yeah, you can do it from the contralateral, no problem.
So some mumbling from our panelists here, George. I think we're talking about having a protecting balloon coming from the radial side for the right side there, in addition, while the VBX is going up. What are you thinking?
Yeah, no, can you hear me?
Yes, you can.
Okay. Okay, good. So the issue is this distal aorta is severely diseased. I can tell you when I'm going in there with wires, there is plaque, and to get this sheet down there, it's a lot of, I'm afraid that if you go in there with kissing stents, there may be a chance either a dissection or you're gonna throw a lot of stuff distally. The least amount of stuff that we can get in, get out, open this vessel up is what I would prefer. I agree with you. I'll take a balloon down and protect myself on the right as I go up with this short VBX. And let's see how it looks.
Okay. We're going to keep watching and continue the discussion for the last 3 minutes that we have.
Can I get a 7040 balloon?
Any other questions from the panel?
Long shaft. It's got to be a 7.
Otherwise, the rest of it looks really good. I mean, he landed the stent perfectly distally. That's where I would have probably placed it. And it was the right choice of stent.
Dr. Tiagi.
And yeah, I was going to say, you may not lose those collaterals too if you build it up. It's not like you're putting an aortic stent graft in there. So I've done this and raised the bifurcation to the lumbars, and the lumbars still are perfused sometimes.
I think it's the IVUS images that were a little bit scary, right? I think if we saw the IVUS images go, we clearly saw the edge of the VBX, and I think, all of us recognize that as did Dr. Adams, and this is the reason he's treating this. With just the angio, we might not have seen it, but the IVUS gave you a lot of information about the proximal edge is still sitting in thrombus. So I guess we're going to take this VBX up and then put a kissing balloon on the other side as well. Let me ask, so now what percentage of your large bore access, Rami, are you doing IVL for now? Or has it become fairly standard? Is there a certain type of calcium to look for? Or if you see calcium period in your preoperative planning, are you pulling
I'll tell you this, our threshold for using it has gone way down. We've had, I think 2 years ago or so, we had our last iliac rupture. And after that case, we just said, you know what, if we're even thinking about it, we're just going to use it. And so our threshold for using it has certainly gone way down. Certainly any vessel that's sub 5.5 with moderate calcification, so 50% calcification, I think it's worth using. The issue is not just getting the preliminary sheath up, especially with like the Edwards valve. You need to, the actual vessel needs to expand while the valve is going through the E sheath, and so you need that compliance. And it's just it's safer. And then the number of covered stents we've had to place and the number of iliac complications we've had to deal with is lower, and we're actually looking at that data currently.
I think we have last kind of 45 seconds left to this session. I think before anything, in case we run out of time here, Dr. Adams and his entire team down at UNC and the patients down at UNC as well, we want to give you a real sincere thank you from New York. We've had you working all day, even from the morning session, even till now, and thank you for sharing these wonderful cases with us that have been a real good learning opportunity. I think, can we just give him a round of applause first?
Thanks, Sean.
And PK is coming up to the mic because I know he has some words for you as well.
No, George, thank you for that wonderful demonstration for this morning and today. Really can't appreciate you enough. But I just have a question for the panel. Everybody talks about IVL with followed by stenting. Forget about TAVRs, obviously it's a different animal, Rami. But what about in calcified iliacs? I mean, the data with COBEST and other covered stents is so phenomenal. The cost with IVL followed by these stenting could actually make you lose money. So do we need more data to say IVL becomes prime time for all calcific lesions, or do we reserve IVL for certain subsets that we're still not aware which is the right one?
I think we're going to be okay.
My personal opinion is that I would
take it off subtraction.
reserve it and for selected cases. I think when you're using it for access in a vessel that's patent in a patient that doesn't have symptomatic claudication or limb ischemia and you need it just to create your access, I think that's a great way to potentially leave nothing behind. But if you're treating complex disease, I would go with the primary stenting role. I do think that IVL has another application, and I've had some patients who have had bare metal stents that have been placed previously and were underexpanded because the vessel was so calcified, and you can go in with IVL after the fact and post-dilate those stents and sometimes effectively get them open using the IVL.
we're talking about cost a little bit, but if you have a very calcified lesion, would you pull 2 IVL balloons and do kissing IVL balloons as well? Have people done that?
Only Chris Metzger. He did a live case at TCT like that last year. So, no, I think that you need to get the vessel expanded, and whatever it takes to get it expanded. We have a pretty big TAVR program at Columbia, and
How's it look out there? What do you
they're
think?
used to selective.
PK, do we go back to Dr. Adams for a final word?
Is it this?
Yeah.
I'd maybe go in just a touch.
Yeah.
You think it needs to go in a little bit?
Yes.
That's what I was thinking, yeah.
Yes.
George, we're here with the course director, so I think we get to go until he says no more. So we're all watching you in this room very intently.
Okay.
And that looks really good.
Yeah.
You like that?
That's good.
Okay.
Perfect.
A lot of head nods.
Which one's this? Okay, you ready? Here we go. Going up.
It's funny, we don't get consensus about anything here.
Good, come on down. All right, guys,
George, what size was the right-sided balloon that you had?
7.
That's how,
just a 7. It's undersized, but just to protect me, that's all I'm doing. All right, do me a favor, let's get, yeah.
What pressure did you take
not
that
this.
VBX
Let's get
to?
this.
Did you max it out?
I think rated is 14, I took it to 20. Did you hear me?
Yeah, so that gets you like to 7.6 or something like that?
Yeah, at least. I mean, I took it to 20. I don't know. It's off the scale. I wanted to make sure that I was opposed because I took an 8.0 balloon prior.
I think this is why some of these live cases are absolutely amazing. George was flying through this case. We're like, oh, we're going to be done in like 30 minutes. And then since then, we've had a lot of things to talk about. And for sure, having that concurrent access from the radial here added so much to this case to be able to do the imaging and to do the protection at the other side.
Here we go.
All right.
Yeah. I tell you, that looks good.
Yep.
No IVUS. Okay.
Let's IVUS. Let's IVUS.
So George, thank you so much. From all of us in New York, really, you were wonderful. Your team, everyone there, thank you so much for everything. Panelists, thank you for your talks. I think it was a wonderful session, and we'll get ready to move on to the next. A final bye-bye to you, George.
Great job.
Thank you.